And I'd like to request our next presenter, Dr. Prathap. He will be talking on drug-coating balloon, when and how.
Thank you, Chairpersons. Drug-coating balloon, when and how. The late stent thrombosis and restenosis 2% per year after implantation that make a drug-eluting stent, even drug-eluting stent, you get a 2% restenosis. The concept is actually with a highly lipophilic drugs, even with a shorter contact time between the balloon surface and the vessel wall, are sufficient for the effective drug delivery. Fast and homogeneous transfer of anti-proliferative drugs during single balloon inflation without use of permanent implants. What is the DCB technology? The combination therapy of balloon and a drug. It eliminates stent thrombosis and achieving a lower rates of restenosis by leaving no metal behind. It's actually having a plaque of neointima in the arterial wall, and these are the drug surface actually taken. The guidelines telling that the drug-coating balloons are recommended for the treatment of ISR, of BMS or DUS as 1A indication. The randomized trial data supporting the use of drug-eluting DCB angioplasty are limited to the treatment of ISR. At present, there is no convincing data to support the use of DCB angioplasty in de novo disease. The two main approaches in de novo. It can be a combination therapy, DCB initially, and then a BMS or DIS. Or leaving nothing behind the strategy, that's DCB and the stent is implanted only as a bailout strategy. Advantage in a bailout strategy, leaving no metal in the blood vessel and respecting the vessel anatomy. Combination therapy, advantage of delivering anti-proliferative drug by DCB and overcoming mechanical complications of balloon angioplasty. DCB and BMS versus DS. Most of the trials shows inferior result with a combined therapy of DCB and BMS when compared with a DS alone. DCB in a side branch with a stent in the main branch. As with other combinations of trials, DCB can be used in bifurcation disease. Did not translate to improve the clinical outcome. Why DCB perform inferior in trials? 1. Geographic mismatch of the stent placement in area not covered by the DCB. Variation in the vessel preparation in the terms of pre-dilatation. Variation in inflation time of the DCB to transfer the drug to the wall. Shorten the inflation time may not be enough to deliver the adequate amount of drug. The excipient type can differ in efficacy to transfer the drug and release into the vessel wall as shown in different pharmacokinetic studies. DCB and BMS versus BMS. The combined intervention strategy consistently has shown superiority over BMS. The potential alternative is actually in high bleeding risk patients, as they only need a shorter term of antiplatelet therapy. The combination therapy of DCB and DUS. For high restenosis risk patients, long de novo lesions and diffuse CAD. This is actually a therapy is started coming up with the Colombo is doing almost all cases. DUS in the proximal lesion, DCB in the distal lesions. In diffuse disease, sequential lesions can be treated separately, and there should be no overlap between the treated segments because of the high risk of restenosis. Advantage, overall reduction in stent length, which in turn beneficial for a lower ISR. There are a lot of devices available for the DCB. I'm not going to how to use the DCB and tips and tricks. Basically, acceptable angiograph result should be there. So you should have an optimal lesion preparation is important. Standard semi-compliant balloon, scoring, cutting or non-compliant, balloon to vessel ratio is 1:1. Then options you can use, even rotablation and something. Then go to DCB and DUS. Suboptimal angiographic result only you have to use a DUS. Lesion preparation is actually with the balloon to artery ratios 1:1. After lesion preparation, confirm optimal balloon angioplasty result and then deliver the DCB. A pre-dilatation is an important step. It creates microdissection which are required for optimal uptake of the drug. DCB are intended only to deliver the drug but not to prepare the lesion. So preparation of the lesion should be done by another balloon. Anticipated difficult balloon delivery. You start with a smaller balloon and reassess the vessel size after the use of vasodilators. Expansion failure of the standard cut balloon, the high pressure balloon or cutting balloon can be recommended. In ISR, aggressive pre-dilatation to tackle severe stent under expansion. The optimum lesion preparation, reduces the event rate after DCB interventions of ISR. Type A and Type B dissections, you can save to leave. Only Type C dissection requires stent implantation. The first generation DCB, less deliverable than standard balloons. Now the current generation, improved deliverability is there. So very distal lesions, extreme tortuosity, extreme calcification. There is a possibility of DCB delivery failure, but if you prepare the lesion well, it is not a problem. And you should don't touch the DCB. Some brands may shed the drug and carrier when touched or after contact with the blood. Be aware with the maximum transit time and minimum inflation time for the drug delivery. Reinsertion of the same DCB after delivery failure is not recommended. Lesion plus at least 2 millimeters proximally or distally should be covered with a DCB. For example, it's a 30 millimeter lesion, you should have a 32, or if a 27 millimeter, you can have a 30 millimeter DCB. Potential indications, angiogram indications, ISR, de novo lesions in small vessels, de novo lesions in larger vessels, bifurcations. Clinical indications, diabetes, high bleeding risk, acute coronary syndrome. ISR is beneficial in both BMS ISR and DES ISR. DCB instead of repeat DES. Patients with the multiple previous 10 layers, those with the relevant side branches emerging from stent and ISR, those who need a shorter antiplatelet regimen. De novo lesions in small vessels, basket small 2 trial shows that non-inferior to DCT to the second generation DES. Higher rates of restenosis in small vessels, so DCB can be an advantageous thing. Basket small 2 trials, similar event rate with the DES. In larger vessels, randomized data is definitely lacking. Bifurcation, DCB in side branch and DES in MB is better. DCB in both MB and side branch. If you see that, preferable to balloon angioplasty alone. DCB only PCI in bifurcation lesion in Medina 011 when compared with the balloon angioplasty alone or a ostial circumflex lesion, then it is useful. Diabetes, diffuse and long lesions with a small vessel caliber with a reduced coronary vascular disk. DCB, it is an alternative to DES. They are not subject to cracks and inhomogeneous distribution of clotting as observed in DES. In high bleeding risk, recommended dosage of DAPT is only for 4 weeks. After that, you can leave it. Acute coronary syndrome, correct vessel sizing. Thrombus may inhibit the drug level of the vessel wall. So actually, DCB only strategy was non-inferior to stent treatment in STEMI trials. In STEMI, immediate and stable result of paramount importance. Current body of evidence does not support use of DCB in high-risk situations. Actually, this is a patient, actually I did a retrograde C2 intervention. After a CABG, patient came back with complete occlusion of LMCA. I'm not going into details. We just did a reverse retrograde C2 intervention with a lot of difficulty. I put a stent across. I just wanted to, after putting a stent with a IVUS guided intervention, produced an excellent result. The patient came back with restenosis within 3 months. This was the result. The patient came back within 3 months, complete occlusion. We did a DEB in this patient with a magic touch balloon. What we did is actually, we did a long balloon dilatation after preparation, after cutting balloon, after doing an OCT. And we kept one balloon there and magic touch balloon on the other side. We produced a result like this. This patient is doing very well for the last 18 months. Thank you very much. If you want, actually I have one more talk. That is my favorite topic. Serocontrast PCI. I do serocontrast, but you can use some contrast. Impact of the contrast in this nephropathy is actually increased hospital stay, irreversible kidney injury, need for dialysis and death. How to reduce the mortality? Prevention is the key. How to reduce prevention? Reduce the contrast volume. What is actually ultra low contrast? That is what I am telling. The contrast volume should be less than GFR. That's the point. When you use that, the evidence of contrast-induced kidney injury is 0%. I try to do serocontrast. Which are the indications? 1, eGFR is less than 30. or if the creatinine is more than 1.5 or eGFR is less than 45 in a patient more than 75 years, ejection fraction is less than 50%, diabetic patient, hypotensive, MI or anemia, where we use that. This one case I will show you, ejection fraction 20% with eGFR of 38. This was the angiogram. Angiogram is taken, which is actually having a lesion in circumflex, ramus as well as LAD. We had four shots taken by the previous operator. We tried to take, keeping the wire on the right side, you can see the right angiogram, that is actually the reference. I take the first wire into the distal circumflex. Then we take the second wire into the distal branch. Then we have a reference actually as there is a cornus artery coming from the top. You can have a sinus nodal artery. So 3 branches, 3 wires. 2 are the marker wires and the other one is actually the reference marker. When you took a 1.5 millimeter balloon, after that only we could take an IVUS. We took an IVUS. After the IVUS, we understood there is a 3 millimeter proximal vessel. Distally is only 2.6 millimeter. The lesion length was 22 millimeters. We did a balloon dilatation of 2.5 into 15 millimeters because the vessel is 3 millimeter proximally. How I measure is, we have a 3 millimeter proximally, that is after the first branch. The lesion starts 2 millimeter away from the branch, but the lesion ends 8 millimeters before that. So we have a 2.3 millimeter proximally and a 2.75 millimeter distally. What I took a 2.75 into 22 millimeters the lesion length, but I have 32 millimeters between the 2 branches. So I took a 28 millimeter long stent. Then 2.75 into 28. Then 3 millimeter proximal vessel. So after that, I did a post-IVUS. Then I showed that this is actually having an underexpansion. When I did an underexpansion, I went with a 3 into 15 millimeter throughout. I did one more IVUS to understand the vessel stent is opened up very well, showing not opened up properly in the proximal part. We went to 3.5 into 8, proximally only for 4 millimeters. Finally, we got a fully expanded stent throughout the vessel. Then we went into out of the 3 wires, the first wire, is only 1 wire required in the circumflex, the second wire taken in the ramus. You can see that the IVUS catheter was not going smoothly. So what I did is, I did a dilatation there. But whatever I see in the proximal part, I was in the vessel. So I saw that vessel is proximally 2.7 to 2.85. So I took a 2.5 millimeter balloon, then I did an IVUS to understand the lesion length. After that, I understood the lesion length was 30 millimeters. So I can take the next stent size was 33. I took a 33 millimeter stent, 2.75 millimeter stent into 33, keeping 2 wires on the LAD and circumflex as the marker wires. Then I did a proximal dilatation of 3 millimeter balloon. After that, what I did is actually I did an IVUS to understand it is well expanded throughout. So now the next focus is actually on the LAD. I have 3 wires, 1 wire into the circumflex, 1 wire into the ramus, 1 wire to the LAD and 1 wire into the diagonal. You can see that the angiogram is there. I put the wire into the diagonal. So diagonal alone is not sufficient. What I understood is distal vessel is 2.7 and the disease extends to up to the ostium. So I put a wire into I don't want the circumflex wire now. I put the wire into the septal artery. So 1 wire into the septal, 1 wire into the diagonal. The second septal is the point of the lesion. So I did a balloon dilatation. Then I understood ostial LAD is 4.1 millimeter, distal is 2.75. The ostial LAD to the bifurcation of diagonal was 15 millimeters, diameter is 4 millimeters. After that it is 24 millimeters and the diameter is 2.3 millimeters. So I put a 4 into 15 stent from the ostium, keeping the branch wire onto the circumflex as the reference mark. After that, then I have 2 wires is there. So I have to take a 2.75 just beyond the second septal, because second septal only the disease was there. So 3 into 28 stent with an overlapping. So then I removed both the wires from the septal as well as from the diagonal. I post dilated with a 3.5 millimeter balloon proximally. Then I did a IVS run again. The total I was showing well expanded stent, no ostial pinching, all the vessels are perfect. What we done actually, 10 IVS runs in the case, circumflex 4 runs, ramus 3 runs, LED 3 runs. I have done so far 77 cases, published a lot of data regarding these things. You can verify, these are the data available. I have done 23 cases in left main, 5 rotablation, 5 CTOs, including 1 retrograde CTO, complete absolute zero contrast. But even in these cases, in the 6 vessels, I have to check with some contrast because the patient complains of severe pain or ECG variation. These are the published data available. Thank you very much.
Thank you, Dr. Prathap.
I don't know whether I could reach to you properly or not.
Thank you, Dr. Prathap. I have a question for you. How much dye do you use in CAG of your cases?
CAG actually done 15 ml of contrast is more than sufficient for 4 shots. Actually, the people you should cannulate properly, withdraw the blood. How do you identify whether your catheter is in the coronary? That is a simple question. When you put the catheter into the coronary, you push some saline. Especially if it is a cold saline, will have ECG variation. You look at any angiogram you do normally also. You push some saline, you will have an ECG variation. Earlier I was thinking that I am finding out something great. No. When you just push anything cold, you will create a variation in ECG. That's actually one way to understand you are in there. Or a metallic solute or the calcium in the ostium of the LMC. You can identify the vessel is in there. Number 3 is actually, you put the wire. The wire actually, whatever the reference angiogram you have, if you have a circumflex lying like this, don't believe that you are in circumflex. You go to the next angiogram which is available with you. That means epicranial. Your circle will be looking up. Then you go there. The wire is in the same direction. You are sure that you are in the vessel. If you want to identify again, you take a IVS catheter down and see that vessel is in the vessel or not.
Thank you.
Okay, we now conclude the, sorry, is it okay? Is it over for you?
Huh?
It's complete?
Huh?
Is it complete for you? Okay.
No questions, I'll go.
Okay. Any question? Any question from any side?
Thank you for great lectures. Suppose your inflation time for DCB is 40 seconds, yeah? 40 seconds we should keep the balloon inflated for DCB, yeah?
No, I'm just telling you that if you have a doubt, when you do most of the people, when you put a catheter inside, when you are very sure that, usually I just aspirate the blood and take the first
not. I was just talking about the previous DCB or DEB. That is the other issue. The previous.
Okay. Previous talk. Okay.
So suppose any patient, if patient complain of pain after 10 or 15 seconds of inflation of the balloon, so
what I do is actually I deflate the balloon, give some time. I don't take the balloon out. Keep the balloon there itself. Then you inflate again. But the major problem actually created in bifurcation stenting is actually keeping 2 balloons inflated together. What I do is a different thing. And a patient of LMCA stenosis, LMCA is coming back with restenosis. I do a different one. I take a drug balloon into the side branch where having a lesion maximum. And if I wanted to take a stent into the other branch and drug-eluting balloon in the other branch, what I do is I inflate the drug balloon first and go up to 90 to 1 minute there. When you do a bifurcation, that with the same balloon and the stent down, for 10 seconds, you can take it out and finish it off. Most of the trials, what happened, they wanted to take the drug balloon, the same time you cannot keep the balloon there. The bifurcation ballooning actually, the drug balloon only requires 1 minute 10 seconds. That is 60 to 80 seconds required.
Yes.
Other thing is not required that.
Thank you, sir. Okay. So otherwise, suppose 3.5 millimeter vessel, but I don't have any 3.5 millimeter DCB. 3 millimeter DCB balloon is available. I have pre-dilated it with 3.5 millimeter NC balloon. But if we put the 3 millimeter balloon with a high pressure 18 atm, more or less a position is there with the wall of the vessel. No. Does it work?
No, what type of DCB you wanted to take a lower size balloon? No. In ISR, you should take the 1:1 ratio itself, number one. You should pre-dilate the vessel very well to create the exact lumen. If you don't have a 3.5, the vessel is 3.5. Ideally, you should take a 3.5 itself. That is, otherwise you will not get the ideal drug delivery. That's a problem. And the same as IVL, what he told earlier.
Yeah, and you must remember that your DCB should be the last instrumentation.
Correct.
Not the first. So you dilate well, you expand, you make sure that the lesion is fully dilated 1:1, and then you put the DCB in. And I generally, the minimum is 1 minute. I tend to do, and Prathap also, we do for 2-3 minutes, because it's been shown that prolonged inflation patches up all dissections also. So that's always a good thing.
So one more thing I just wanted to tell people, even I don't do an IVS after that, because I don't want to do anything after that.
No instrumentation.
Only an injection come out. And people will do everything, but after that, whatever work you have to do before that.
Okay, thank you very much. I think we have concluded the session.